So thank you for being here this afternoon. I was asked to address the question, opioid-free surgery, is that nonsense or is it next standard of care? These are my disclosures. The last two companies make medications that are relevant to this topic, one of which is commercially available, one of which is not commercially available. But I think that's why I was asked to give this presentation. The only thing I'm going to say about those two medications at the end of the talk is what's already been published. So why are we talking about opioid-free recovery, not just opioid reduction after surgery? That's our first topic. We'll briefly talk about ERAS, but not spend too much on it. We're going to focus primarily on multimodal analgesia protocols, especially those recent guidelines published in the 2022 SAGES ASCARS guidelines. We'll talk briefly about what our current opioid prescribing recommendations post-op probably ought to be, and then look at some future options. So again, why are we talking about an opioid-free recovery, not just an opioid-reduced recovery? Opium's been around for thousands of years. Products have been available since the 1800s, and there's always been some abuse. But there's never been what we've seen in the way of abuse over the last 20 years. And why is that? So in 1995, the American Pain Society published a guideline in JAMA defining pain in a new way as the fifth vital sign. And hospitals adopted that starting in about 1999. And the problem with that is it reframed in the minds of patients their expectations. They went from expecting a normal amount of postoperative pain to expecting little or no pain, and it reset the expectations. And that was reflected in satisfaction scores. In some areas, it was reflected in reimbursement. And so pressures were applied to prescribe more opioids to minimize pain as close to none as possible. And there were bad outcomes of that. And opioid prescribing peaked in about 2010 or 2012, but the problems that were relevant to this audience and with acute post-op prescriptions of opioids are the top two there: opioid use disorder and diversion misuse. This audience may not be aware, and I wasn't until I started looking into this, that patients who are opioid naive at the time of surgery, they have their operation, we give them a prescription, that's their first exposure to opioids. Multiple studies, multiple operations, multiple countries show that there's about 1% of those patients after first exposure become chronic opioid users, defined as multiple prescription refills over at least 6 months or at least 10 prescription refills. So about 1% of our patients are becoming chronic users. And then as far as diversion and misuse, we used to prescribe about 30 pills at the time of discharge. It turns out more than half of those are not used by the patient. They're rarely disposed of properly. They end up in medicine cabinets and available for diversion and misuse. And that's unfortunately how a lot of our adolescents in middle school and high school are first exposed to opioids. And so that's a contributing factor to the opioid epidemic that we see now. So the same forces that were pushing us to prescribe opioids between about 1999 and 2012 are now pushing us away from prescribing, but we still have an obligation to help patients through their recovery, right, with less pain, a good recovery, good mobilization, early discharge, and so forth. So how do we accomplish that? We accomplish it with good ERAS protocols and multimodal analgesia protocols. Now, ERAS looks at the whole patient journey perioperatively, and I'm not going to go into that in our short time today. I'm going to assume that this audience has all implemented this at this point. We have a decade of level 1 data that tell us that ERAS protocols drop complication rates, they drop lengths of stay, they drop costs, and they improve patient satisfaction. So I'm going to take that as a given. The multimodal analgesia protocols is what we're going to focus on today, and that looks just at the perioperative pain management. Now again, we're talking just about protocols for acute pain, specifically the subset of acute pain that's postoperative pain. We're not talking about the management of chronic pain or pain at end of life. Those are completely separate discussions. So within the field of GI surgery, we have clinical practice guidelines now in almost every subspecialty that we practice in that have been written and published over the last decade. The most recent of these are the 2022 guidelines that were jointly published by SAGES and ASCARS. Now, we won't go into it as much today as I wish we had more time for, but the preoperative education is critical. The education and expectation setting of patients and families has to be established before the operation, or there's going to be problems afterward. So with a multimodal protocol, we're looking at different classes of medications that affect pain at various levels of the peripheral and central nervous system, starting with local anesthetics and nonsteroidal COX-2 inhibitors that act peripherally, ketamine for non-opiate anesthesia protocols, and then acetaminophen also acts centrally, and then our last choice, of course, is opioids, which act centrally. So SAGES has on its website an ERAS manual, it has the Enhanced Recovery Protocol Guidelines, and it has the 2022 Clinical Practice Guidelines, which is what we're going to focus on now. So within the ERAS guidelines are two guidelines specific to pain control. The first states that a multimodal opioid-sparing pain pain management plan should be implemented before the induction of anesthesia. So what are the details that go with this that make it important? The first detail is that the first dose of acetaminophen and either nonsteroidal COX-2 inhibitor needs to be given before the skin incision. We know from the anesthesia literature, including this meta-analysis that looks at 5 different anesthetic approaches, that the data on nonsteroidal use shows best effectiveness if the first dose is before treatment, which defined here in the meta-analysis means before skin incision. And it turns out this data are also similar for the amide local anesthetic use. They work best if the first application is before incision. So again, level 1 data, meta-analysis data. What about postoperative use? The postoperative use of the acetaminophen and the ibuprofen or the COX-2 inhibitors has to be scheduled for the first 72 hours. If you use those medications on a PRN basis for the first 72 hours, there's more episodes of breakthrough pain, and then there's more episodes of opioid use for rescue. So the key on the postoperative prescribing is that for the first 72 hours, those have to be scheduled medications. What's the downside of that, right? So what's the effect on the kidneys? What's the effect on the GI tract, right? So the guidelines state that nonsteroidals should not be withheld from adults with normal renal function. The data on 3 days of nonsteroidal or COX-2 inhibitor use perioperatively shows transient or no effect on the kidneys, and the transient effects, when they do occur, are self-limited. So there's no contraindication to 3 days of nonsteroidal use in adults with normal renal function. What about the effect on the GI tract? You heard it mentioned a minute ago, but there are animal data and human data that show that if diclofenac is the nonsteroidal that you're using, you're going to increase your perioperative GI leak rates by roughly 2-fold, or a little bit over 2-fold. So that should not be your nonsteroidal of choice. The data also show that there's no increase in leak rates with any of the other nonsteroidals or COX-2 inhibitors. So for your perioperative protocol, diclofenac is not your choice. What about the doses? These are standard doses, so there's nothing unique about the dosing of the acetaminophen, the ibuprofen, or the celecoxib. The regimen that I use is what was at the bottom, and that's because it's easy to use, easy for patients to remember, and easy to use, right? So I tell them to take 1,000 milligrams of acetaminophen and 600 milligrams of ibuprofen 3 times a day for 3 days. Why that dose? Why that regimen? So that's 3 grams of acetaminophen a day, 1,800 of ibuprofen a day, safe dose. I tell them 3 times, take it in the morning when you get up, take it in the afternoon, take it at night, about an hour before you go to bed. It's easy to remember. I tell them to take it together. Is there any difference whether you give these medications together every 8 hours or alternating every 4 hours? The answer is no. If you look at the adverse event profile and the clinical effectiveness, they're essentially interchangeable. So if you have a patient that wants to take something every 4 hours, have them alternate it. If they don't have that preference, I think it's easier for them to remember just to take them together 3 times a day, morning when they get up, afternoon, and about an hour before bedtime. What about gabapentinoids? So gabapentinoids have a role in chronic pain management, or at least some chronic pain management. In the earlier protocols, multimodal and ERS protocols, they were often included in those protocols. But we have enough data now, level 1 data now, and reviews of the data showing that 3 days of gabapentinoids perioperatively are not beneficial for postoperative pain control, and they do have some adverse events. And so although they were often used earlier on, those are now not recommended in the protocols. Local anesthetics, so the standard amide local anesthetics, lidocaine and bupivacaine, those are effective. They can be used at the surgical site and or in blocks. TAP blocks are beneficial, whether they're applied with ultrasound guidance in the pre-op holding area or intraoperatively under laparoscopic guidance. They work about the same, and they do reduce opioid consumption. What about the longer-acting products, right? So there are 4 commercially available longer or intended to be longer-acting products, right? There's liposomal bupivacaine, bupivacaine and collagen sponges for hernia surgery, bupivacaine with pumps and catheters, and then the combined bupivacaine meloxicam products. So 4 commercially available products. The only one addressed in the most recent guidelines, the 2022 guidelines, is liposomal bupivacaine, and the guidelines point out that the data are controversial regarding a purported extended duration of benefit of liposomal bupivacaine. What about thoracic epidural analgesias? So this is another guideline in this 22 guidelines, and it states that while not recommended for routine use in laparoscopic colorectal surgery, it is an option for open colorectal surgery if a dedicated acute pain team is available for postoperative management. So a lower thoracic epidural is effective in open abdominal surgery. It does reduce postoperative pain scores, and it does reduce opioid use. Unfortunately, it does not have any benefit over good multimodal protocols and local anesthesia blocks in laparoscopic surgery. And then results are variable for single-dose spinal analgesia, IV lidocaine, continuous wound infusions through pumps and catheters, and non-TAP abdominal trunk blocks. So in summary, the multimodal analgesia protocols, they are effective. They should include local anesthetics. And again, you can talk about short versus long term. Regular non-opioid analgesics, so that's your acetaminophen and either your non-steroidal or COX-2 inhibitor. Regular means the first dose is before the skin incision and the post-operative doses are scheduled for 72 hours. And if we do that, how little opioids can we get away with? So we know from the data in Michigan, as well as published data from Hopkins and Dartmouth and other places, that with a good multimodal non-opioid protocol, we should not have to give our patients more than 0 to 5 or 0 to 10 pain pills after surgery. They shouldn't need more than that, and in at least 80 to 90% of our post-op patients. So if you go down the list of operations, so fundoplication, lysis of adhesions, appendectomy, cholecystectomy, colectomy, lap and open, hernia repair, on down the line, almost everything that we do in this room, we should not be giving more than 5 or 10 oxycodone 5 milligram tablets, no refills post-op. Now, can we do better than that? Can we get to less than 0 to 5 or 0 to 10, right? Can we get to 0? So 2 things to be aware of. One is the extended release bupivacaine meloxicam product that was just approved by the FDA a couple of years ago, and the indications were just expanded in January of this year. And that's been studied in soft tissue surgery as well as bony surgery. The soft tissue surgery data is closest to what we do with abdominal incisions. And that data shows that the product does work for 72 hours, and when it's wrapped with a good non-opioid multimodal protocol for 72 hours, the pain scores generally don't exceed 2 to 3 out of 10. They're in the mid portion of the mild range, and roughly 90% of patients can have a completely opioid-free recovery. So no opioid use in the hospital, no opioid use after they go home. And in the hernia studies, there's no opioid prescription at discharge. The other technology that you may want to be aware of, I've lost my advancement. Go ahead and advance it 1 for me if you would. Maybe I can do it. Thank you. The other technology that you may want to be aware of is a NaV1.8 inhibitor. Now, these products are not commercially available yet. What's a NaV1.8 inhibitor? That's an oral medication that acts on peripheral neurons. So the sodium channels in neurons are different at different levels of the peripheral and central nervous system. The sodium 1.8 channels, or the NaV1.8 channels, are only in peripheral neurons. So these are medications that are delivered orally and act on peripheral neurons to block that sodium channel so that the peripheral neurons cannot generate the first pain signal. So these have been studied for between 10 and 20 years. Enough of these have done, 2 of these have done well in animal studies and have now made it through human studies. One of those 2 has done well enough in human studies that the data were published in the New England Journal of Medicine a couple of months ago, so if you want to go look at that. They're not commercially available yet. They may be in the near future, but it's something you probably ought to be aware of that may be coming down the line, because if this works out, this would give us a 4th pillar along with our amide local anesthetics, our acetaminophen, our non-steroidal and COX-2 inhibitors. This would be a 4th pillar of a peripheral nerve blocker. So just something to be aware of. So the question I was asked to address was opioid-free surgery. Is that nonsense or is it next standard of care? Well, it's not nonsense. We can certainly accomplish it. I don't know that we can call it next standard of care because we're not there 100%, but we're moving along pretty close. So thank you for your time.